Across the table, we've got Sean Sullivan here with Hospice of Tennessee. I'm really looking forward to this conversation, and I know a lot of our audience is too. A lot of folks that are listening have gone through the hospice process with a grandparent, a parent, or a spouse. Or they're just overall interested. If they've not had involvement with hospice, a lot of our families will be touched with it at some time. And Sean, why don't you just kind of introduce, yourself and kind of what the mission statement is of Hospice of Tennessee?
Well, of course, I'm a community liaison with Hospice of Tennessee, which is, it's really almost, they would almost call it like a marketer, but I really don't consider it to be that because we're dealing with a human element.
Right, ambassador.
Lives. Yes, an ambassador. Of course, liaison just means bringing, groups that work in like fields together, to help them serve other people. But our mission statement really is just to basically serve the needs and meet the needs of people with excellent quality care at the end of life. Helping people to finish well, and there's so much you could wrap up into that, because there's the physical end, there's the financial end, there's the emotional end, there's the relational end, so there's a whole lot that comes to the table.
And some of the finest people I have learned are drawn into whether they are registered nurses, they are DSPs, they're just caregivers and physicians. I mean, it is just, I rarely ever have a client who's rendered some negative story in regards to palliative or hospice care at the end. One of the things, I'll just ask you a few open-ended questions here. There's so much we could talk about with the history of hospice and where we are today and the options. People always wonder, do we have to go home? Can I get institutional care at a nursing facility, a hospital? Just a kind of, why don't you break down the different environments in which hospice can actually be rendered?
Okay.
I think a lot of people don't really know that.
Yeah, it's pretty open-ended. We have a lot of people that prefer to get their care at home. They want to be surrounded by their loved ones in that home environment and prefer not to have a clinical environment. We work there. We work in assisted living facilities, which is essentially their home.
It's been their home maybe for the last couple of years, right?
Yes, so we go into that. We have skilled nursing facilities that we can go into. Your more traditional nursing homes that are there, we work in that capacity. And then in emergency situations, we have the ability to go do what's called general inpatient, where if we're dealing with a very rough illness where maybe there's pain, there's nausea, there's symptoms that you're struggling to control, you have the ability to be moved temporarily into, a Cookeville Regional or
into a hospital
itself, until we get those done. And then there are not many of them. There are some inpatient hospice facilities, but almost as a rule, the companies that offer the inpatient hospice, they reserve that to the very end of your life. So you're, a week, 10 days out from passing, and you have the ability. But Cookeville currently does not have that.
I had a very, very good mentor and friend in the Army Reserve. He was a master sergeant, just beloved figure in his early 50s, and came to the drill weekend, ended up having stomach cancer, did not look well, and it was a very progressive cancer, and he did have the last couple of weeks of his life in Arkansas in one of those facilities. I didn't get a chance to go down there and see him. A lot of the unit did, and it was really nice. When would someone be a candidate for something like that? Is it just, I guess it's the needs of the care.
Well, the need of the care drives that, or in some cases, like I lost my own father to metastatic prostate cancer. He wanted to be at home, and there was a while where my mom wasn't sure that she wanted to remain where he passed and have that memory. Some families are okay with it, others struggle with that.
Okay.
And so if that is a major struggle, there are other ways to get it taken care of. And there are ways we can do it too. Let's say, for example, here in Cookeville, even though there's not an inpatient hospice per se, if we're tracking that disease process and we get it down to where we know they're just a few days, we can get what's called a respite stay, where we can go to a skilled nursing facility and get them a 5-day stay at one of the skilled nursing facilities. That's a possible. It's not done often, but it's a way you can achieve the same thing.
If it's a primary struggle in that marriage or in that family, and that's actually really good to know some of these specifics. Something else, I hate to go into the money, questions, but so many people ask, as estate planning professionals, we're getting a TennCare for long-term care benefits, we're achieving Medicaid, we're looking at the private market, and then hospice comes in, and in general, please speak to this,
Sure.
too, but Medicare covers a lot of hospice and palliative care, or am I
Yes.
overstepping almost always, or is that too broad of a statement?
No, not really.
Okay.
Our organization, actually, we accept all
Insurances,
so it's good that way. Medicare is the primary driver of the hospice benefit itself.
Okay.
It's 100% paid for. The charges vary. They pay 100%. The
Yep.
client for the actual hospice service pays zero. So that includes a lot of things. That includes their nursing visits, the doctor's oversights, the aides coming out, the social workers' participation, the chaplains that would come out, take care of them, their comfort medications, their durable medical equipment that they may need. All of those things are paid for by that. So you have that. There is a Medicaid or a TennCare benefit that's there as well. We have veterans that maybe
VA,
sometimes bring VA. And in some cases, and it's very difficult, we may and we do pick up on occasion indigent cases where they're literally the least of these people in a desperate situation who just don't have anything. So it's pretty broad and pretty sweeping. Yeah. And Medicare is the primary
driver looking at any individual case that they do largely cover 100% of the services. So that's great to know. So I know a lot of listeners are thinking about that.
Can I show a quick caveat on this too? So a lot of times people will look and say, okay, well, Medicare will pay for it, so I'll just go in and I'll go to a skilled nursing facility.
They got room and board, right?
They've got room and board, so Medicare is not going to pay for
that. Yeah,
that's right. Now, if they don't have a large asset base, they may be able to get Medicaid that would assist with it, but
otherwise, be prepared for a private daily rate.
Private daily rate, yes, and the potential for a spend down later, that type of thing.
Yeah, thank you for adding that actually, because it is on a case by case basis. People are receiving hospice in a skilled nursing facility, right? Yes. So. You mentioned chaplain services. We have occasionally worked with. I don't love that death doula name brand, but really social workers that are specific with grief counseling and end of life care and things. And they do that's a burgeoning kind of industry in and of itself. Also, that's covered through hospice.
Yes.
Give maybe a couple of examples of how someone's faith can be supported if it's not by their own local church or they don't have someone in the family and they're struggling there. You mentioned like a chaplain. How is that done?
Well, and there are a lot of things, and I want to be very careful in where I go because faith is a big part of my life, and I'm kind of a doer. Right, I have to stay in my own lane. Each person has their own. I'm an RN by trade. I was case manager for over a decade in hospice before I became a liaison.
Okay.
So
you were in the trenches.
I was in the trenches, and that's actually how I don't want to say I developed a love for what I do, but more of a love for helping people in a desperate situation. But support, it can be simply a shoulder to cry on. It can be somebody to visit where you can share concerns and grief with. It can be somebody that will be there and will pray with and for you. In some cases, maybe they're separated. Their church is at great distance, or they've moved before they're critical.
Right.
They have no minister to preach at a funeral, so the chaplains are able to bridge that gap as well. We have some folks that say, I'm not really religious, but I'd love somebody to just come out and play checkers with me. And I've seen them do that, so whatever the need is, we're going to do whatever we can to fit the need. Now, myself personally, if I was ever in a situation where it was right there in the moment and that patient or the family was requesting prayer, I'm going to help them pray. I'm going to help them.
Yeah, I'm sure you've done that.
Yeah,
many times. These chaplains, and again, this is something that benefit, whether it's Medicare, Blue Cross Blue Shield, actually covers that service.
Yes.
Not just for the individual going through the end of life care through the hospice, but also a spouse needing counseling and things like that.
And we have bereavement coordinators that for a full year after that loved one is gone, we stay in contact. We're an available resource to them so they can reach out. We check in. We make sure that if they're struggling, we can get them some counseling or some help as they adjust to their new reality.
How have you, so you've been in hospice for over 10 years.
Yes.
How have you seen it evolve? Like all of these things, for instance, bereavement benefits, the emotional support, just the the increase in overall medical care. How have things kind of gone over the last 10 years?
Well, we're seeing more and more things that are there to help the people. To be very candid, our greatest challenge is educating the public. People have very strong misconceptions about hospice.
Yes, they do.
I'll give you a real quick example here that is stunning to me. We know that if somebody is dealing with a terminal illness and they're on hospice care, on average, they're going to live 6 to 8 weeks longer.
Okay, all right.
They're going to have much better comfort. They're going to be much better adjusted, more prepared for the end of life event that's coming. Reconciliation can have time to occur. Estranged family members can come together. Forgiveness and healing can be brought to the table, and the family can be there at the time of passing.
I never thought about it in that way. It's almost giving a family, which none of our families are perfect, that reconciliation over a 2-month period to get things done. You know?
Yeah, you will find that when a crisis arrives, all the skeletons in the closet come rushing out.
Yeah.
And so it's difficult that way. But here's the tragedy. The tragedy is Medicare says this, hospice itself is designed to be a 6-month-long benefit. So you have a terminal illness, you have a medical team that is determined that this illness or the comorbidities plus your terminal illness give you an approximate window of 6 months or less.
To live, right? Yeah.
Palliative care is typically the same type of diseases or disorders with comfort issues, but you're looking at a window of 1 to 2 years out. So you're very similar with your needs to a hospice patient, but the debility's not there, you're still able to get around, but you may have some comfort issues. Mm-hmm. You may have some pain, you may have some nausea with COPD, you have shortness of breath, different things. So they both go together, but whereas Medicare has designed it for 6 months, what would you guess the average length of stay across the board in America is for a hospice patient?
Whether it's in home or in a facility or just anything? Well, I guess the 2 months.
18 days. 18 days.
And is that because the families are not applying for it or not, or the?
Yeah, it's they're ill-informed.
Yeah.
It's oftentimes when you're dealing with a difficult situation, your practitioner can be very direct. They can be very straightforward, tell you what you're looking at, but you struggle to hear it. You don't recognize it. Maybe there's some denial there. Maybe it's the perception. A lot of people have the perception that, this is it. They're dying. It's time to call hospice. And that is the most unfortunate perspective in all the world because there's so many benefits. I mean, we do things like, if there's a certain level, we help people do things one last time. Maybe it's helping a family take somebody to a ball game, or if they like to go fishing, help them get out and do that, or go to a theater, or do things where we assist with a lot of things. There's special programs that are set up for those kind of things.
And you'll help coordinate
make it happen. Yes, and we help coordinate it. In some cases, we can help get it facilitated with transport or helping with the oxygen. I've gone along several times simply because the additional stress of doing something like that may make a shortness of breath happen or an exacerbation. So I go as a nurse at the time to go along with them to make sure they can enjoy something that was very important to them.
Yeah, and again, what you're saying is because of the consciousness, maybe it's the American South, maybe it's America in general, is that it's like this death, we got to be at death's door for hospice to come in, and so the average stay is at 18 days, when they really could have had this benefit for 120 days, 150 days, and that's not really happening on average.
And there are benefits beyond just living longer.
Well, yes.
We have, for example, we have nurses that are going in, depending on your acuity, depending on how ill you are, how pronounced your symptoms are at the time, we're going to have typically as a rule at least 2 nursing visits a week. Mm-hmm. If you're going through something 3 times a week, if you're getting really critical, we flip to where you're seeing a nurse every single day.
Yeah.
And there are other things that we can do to help with that, but we tend to catch things early. We're able to get a hold of our medical director. It may be a respiratory infection's coming up, or maybe your blood pressure medication, or your diuretics. We get that extra fluid off because you have, heart failure, or you have renal disease, isn't quite getting it. We can titrate that. We can adjust that medicine, make a change on the fly where you don't have to wait until there's a crisis going on. So it gives you a much greater level of comfort. And here's another thing, it's a really big deal to me, because as you get sicker, getting to your practitioner becomes harder and harder. We have folks on call 24 hours a day, where if something comes up, we come to you, doesn't matter when.
And again, all these benefits could have occurred over again a 6-month time frame, not 2 or 3 weeks.
Yes.
Is it also, and it may just be primarily it's the family saying no or being ill informed. Is it also, do we have an issue with our MDs at the hospitals themselves? Is there this public-private partnership that's not occurring? Are they not making the referral? Could they do a better job educating? Is it some of that, or is it largely on the individual families?
You know, each physician has their own
Of course.
demeanor and bend.
Yeah.
You know, there may be a little bit of that because maybe the physician believes in his ability to manage it and keep it there, so they'll fight to the very end. And maybe they've given a verbal commitment that I'm going to help you with everything within my power to get it. So when that physician is ready to raise the white flag and say, okay, I can't do anymore, we're
we're at 20 days left.
And a lot of it has to do with reading your client, reading the family, knowing what their priorities are. I don't use the word hospice a lot because there's so many
The connotations, once
Yes.
again. Yeah.
So I like to use end-of-life comfort care.
Okay.
Both palliative and hospice are designed specifically for those last stages of life, and they're focused very much on comfort. But that's not just physical comfort. That's emotional comfort.
Yeah.
That's relational comfort. You
Yeah.
know, that's having, learning to have a peace with what's going on.
Yeah.
You know?
Arguably, just as or if not more important are all those factors. I know for me personally it would be. You know, if I was in that position of getting all those things done and being at peace and relationally and all those things. I was going to ask you, as far as I just lost it on that, as far as the physicians and making those referrals. Oh, the advanced directives, you know, those are state forms, which is good because, you know, again, social workers, individual families can download and get these things knocked out. When they're working with their elder law or estate planning professional, the added benefit we get is we can provide a ton of context that a lot of families are ignorant on, the ill-informed. We cannot take away, we can add to and add clauses and context on those provisions. And one of the things that we make admin is, do you want palliative care? Do you want hospice care? And we will make that clearly known in writing. Again, if they're a single individual, they've made their wishes known there, so that they've made that order to the physician. But that's really good to know that on average it's actually 18 days, and there's a variety of factors that are leading to that.
Well, and with this too, and I want to double back to the physician real quick.
Yeah.
A big part of the responsibility that I have is helping the physician to recognize what a hospice patient looks like.
Yeah.
What they look like with COPD, what they look like with congestive heart failure, where they look like they're at with the cancer prognosis and what's going on. Because at some point, you know, the quality of life is going to matter to them, and maybe fighting at some point is creating enough physical difficulty where it's like, I would rather just be comfortable the remainder of the way out.
Yeah, and again, we have so many great doctors. There's so much stress. There's not enough. There's all the issues right now in our medical system. So I'm not saying, it's the doctors that have just too much arrogance. They don't want to learn, but there's just so much on their plates, and I just wonder if more education there could be helpful on when to help these people know. We see cancer patients that are getting obviously still have full competency and capacity, getting their planning done, that have serious liver failure or whatever, and they really don't even they're still coming in and with their spouse and things and doing things. They're not on hospice yet. And again, what you're trying to say is, would you have 24/7 services? We can help get you back to your provider and do all these things. They don't, for whatever reason, they're not understanding that, or they would probably be. They would volunteer for it.
Yeah, and some people, it may be as simple as, I'm not ready to give up yet.
I think, yeah.
You know,
right.
I'm not ready, and you know, we're big believers in autonomy. So that patient and that patient's family have the full right to determine their course, right? So in that sense, let's say for example they came on service with us and they just decided we're not ready for it quite yet. It takes 20 minutes for a rep to come out and fill out one sheet of paper, and they go right back to Medicare or whoever they have.
No problem.
Before. So yeah, we don't do that. And if somebody's thinking that they don't want it, we don't want to obviously push for them to be on the service. We get out there. My objective is to get out there to educate individuals, to help them understand ways in which it could benefit you. And if that's what you feel you're interested in at that time, we'll help you get that done.
Oh, well, that's great. And so, Sean, and so that kind of, let's speak to your liaison role. Are you going out and doing these intakes with the families yourself at the homes and things?
I will do, some call it intake, some will call it info visits. A lot of times, I may get a call from a case manager at the hospital. That case manager may say, well, hey, I've got a family, they're kind of not sure, they don't really know if they fully understand hospice, so I'll go sit down with the family.
Okay.
A lot of times I'll meet with them before they discharge. We know when they're discharging. Other times I'll go to the home and I'll actually sit down, answer as many questions as I can about it, because I also, as much as I'm a believer in autonomy, I'm a huge proponent of informed consent. They need to understand what it is, and we've got to set the proper expectation, or there'll be disappointments and problems.
Oh, yeah, these info sessions are so critical. And so whether it's you or somebody else, that's happening every time. At the hospital, before discharge, at someone's home, getting all of their options on the table so that we are truly meeting that informed consent standard. On the topic of misconceptions and things too, let's talk a little bit about pain management, which I know can be it can vary so dramatically. What's the prognosis? Where are we at as far as approaching the end of our life and things like that? I think part of it too is people think that, that they're going to be on morphine on day one, or even though that is so far from the truth, but there's all these conceptions about, pain medications and hydration plans. And can you kind of speak to how the standard of care is laid out and how that goes? As far as the patient's involvement?
But as far as typically speaking, most, depending on what's going on, do they have a cancer, do they have a COPD, whatever the disorder is, they typically are on some level of a comfort med. It's usually a very conservative level that's there. Right?
Okay.
When we bring somebody on board, we have a pretty routine emergency kit that we place in the home. Because Murphy's Law says that if there is going to be an unexpected change, it's going to happen at 3 o'clock in the morning. In the Upper Cumberland, there's one pharmacy that's open around the clock, and it's not necessarily Walgreens.
Okay.
And it's not necessarily going to be rapid. So what we like to do is we like to place things in for pain, for respiratory crisis, for nausea and vomiting, for anxiety, and certain diseases will kind of dictate what meds. So we'll place that in the home. So let's say, for example, if somebody lives rurally and they're in the outskirts, Putnam County, maybe they're in White County.
Right.
If we get a call at 2 o'clock in the morning, the case manager that's there is going to review with that family, and they are going to teach them how to, if they ever have to, administer those meds. They'll always give an example by showing them physically how it's done. So that way, if we get a call at 3 in the morning and said, hey, Dad is hurting terribly, we gave him his routine meds, nothing is helping, we need help, we are able to walk them to that emergency kit, walk them through drawing up the med that's there on a PRN, or what's called as needed basis. They can administer that med right there, and we say, I'm on my way. So that loved one is not waiting 30, 40 minutes for me to arrive.
And once again, someone at the Hospice of Tennessee is on the phone, right? We're 24/7. Someone's going to help that spouse through the process.
Walk you through it, and then we're on our way out, and we're physically going to come and make sure that we have them comfortable. And let's say, for example, sometimes there are abrupt changes. And that sudden onset pain isn't something that's necessarily going to go back to the previous baseline. We have the ability to get our medical director on that phone 24 hours a day, and then we can adjust that medication based on the need. But our objective is to keep you reasonably comfortable or comfortable. Different people have different thresholds for pain.
Right.
Some people are like, hey, I'm okay at this level here. We want you to maintain the level of comfort that you desire with the least amount of medication needed.
And we go from there.
Once
again, that's why we've got professionals there that we're talking about informed consent and what does comfort look like for you.
My own father struggled with the concept of hospice simply because he had watched a couple of friends that literally waited, and in both of these cases, it was cirrhosis or liver disease.
Yeah.
And they waited till they were actively dying. And that is a very difficult disease to deal with it at the end stage if you've not been medicated, because there are cognitive issues, there's restlessness issues, there's the risk of falling, and you'll see folks that are, jaundiced, and so my dad saw hospice come in. What he didn't recognize is his friends were already dying, right? They probably had 2 to 3 days most. And hospice would come in and would medicate to some of those symptoms to give the patient and the caregiver and their loved ones a little bit of relief, so it wasn't constant stress, constant anxiety. And then he saw them pass quickly. So my dad's perspective is, well,
that's what's going to happen.
They're going to come in, they're going to bring the Grim Reaper with them, they're going to leave him here in the room with me.
Yeah.
And fortunately, I had a very good nurse practitioner where I worked, and she came out and he wanted to see about palliative. She lined out all the palliative meds and said, Richard, she said, I have a question for you though. And he said, sure. He says, I've given you all these meds. I've explained all these meds. You understand what they do. Your wife understands them. Who decides whether or not you take those medications? He said, I do. She said, that's absolutely right. She said, but I'm also the nurse practitioner for our hospice branch. And she said, if I was meeting you today as a hospice nurse practitioner, your meds would be identical. The dosage would be identical to what I'm offering you here. And guess who gets to determine whether or not you take that medication while you're able? He wouldn't answer because my dad's a stubborn Irishman. But she said, you do, Richard. And she says, and besides that, he said, you won't let others care for you. It has to be your wife. She's 5'2", 80 pounds. And it's a full-time job for her. You can get aides to come out and help clean you up. You can have nurses come to the home. You can get all these meds just like you're going to get. Loaded up all the services, talked about all the medical equipment. She says, why would you say no to all this help for your wife?
Did he say no?
No, at that point he said,
let's
do that.
Yeah.
He saw it, and it was really funny because he couldn't see it from me. I have my ethic is a sanctity of life ethic. So I'm not going to do a thing in the world that is going to hasten somebody's passing. Yeah. But he struggled to see that. But I was just thankful. Her name was Rebecca, and she did our family a great service by helping.
And once again, there's a calling there. I mean, we see that somebody was able to get through and see that's you just have a totally different perception of what was actually going on with that standard of care. I know, Sean, that you're a person of faith. I think most people that come into palliative care are. I don't want to be too bold there with that. We all have different faith backgrounds, but it takes a special type of person to do this and interact with people. We're all going to live and die, and it is a spiritual experience. And before we kind of came on live here on the podcast, you were talking about you had a financial background. You've always worked with people, and you had a passion for healthcare. You come into this kind of as a second career. And what drew you into this over any other area of nursing?
I think the need that I saw. I started off my nursing career on 6 North at Cookville Regional. It's a med-surg oncology. Back in the day when I started, people could park at Cookville Regional for an extended period of time and get on hospice care. Not so much anymore.
Yeah.
I mentioned that general inpatient where there's a crisis. It's a 5-day limit. That's kind of how it works now.
Yeah, okay.
So it's a different world in that regard, but I saw the need. I saw the hurt in the spouses and the family members' eyes. I saw the loneliness of the patient, and I recognized that there's a psychosocial, spiritual need here that's every bit as great or greater as their physical need right now. And I, not locally, but I watched somebody come in who I think very quickly changed careers. They came into hospice, and I didn't see the compassion. Now, across the board, I see it everywhere I go. Matter of fact, a friend of mine says this, and I love it. I've stolen it from him. His name is Jewel Jones, and he was one of the chaplains. He said, Sully, I don't have competitors. We don't have competitors at our agency. If somebody else is out here doing what we're doing, they are fellow laborers in a noble cause.
Amen.
They are serving others, and if we pooled all our resources, we still can't meet the need.
There's such a demand.
So that was a part of what called me to that. And I saw people come in And they said, well, I'll give this a try. Well, the rule is you're going to figure out in the first 3 to 4 hours whether or not this is what you're supposed to be doing. And it's at times a very difficult burden to carry. You know, you deal with a lot of emotional things, and you have to be stronger. You grow close to people. I say break the rules. I wouldn't literally break the rules, but they'll say, well, just be careful about how close you get to others. And I used to tell my patients when I was in the field, hey, my name is Sean, I'm a nurse, but I said, first and foremost, I'm going to be a friend that you're going to learn you can count on, that I'm going to be here for you, whatever your need is here. And I went out of my way to make sure that their focus was, oh, here comes my hospice guy. Oh, they're going to talk about this. I wanted to be like, hey, I wonder what kind of crazy stories that character's going to come up with today. We're going to laugh, we're going to have joy, we're going to cry together at times, you know, and we're going to get through the toughest period potentially
of someone's life,
to where we can finish in a glorious way and well.
Oh, well, I don't think anyone could have said that better. You know, that you can tell how much passion you have in the mission that you're on, and what you're doing it's so needed. And even as an attorney, I never thought, you know, I started off my career, you know, in criminal defense, you know, where people's liberty interests are at stake, you know, for right or for wrong, and watching people, you know, lose their liberty sometimes for decades or every day was extremely life-changing for me. We did that for a couple of years, working with the public as a public defender. Coming into more of a you know, white-collar transactional area of the law and estate planning and elder law, very different clientele, I was struck by how emotional it can still be when we're working with someone's life, or we're dealing with people that are coming in their life, they're coming in to get their planning done, so long as there's still capacity. And lots of tears are shed with spouses, and what are we going to do, and how are we going to preserve our assets for care, and all of these things. And then when you start walking them through the transfer of wealth and planning that out, we start getting into long-term care planning and end-of-life care planning. And people have a hard time just walking through that. And so as we start visualizing what that looks like, the next big evolution in our practice is to really provide, okay, we filled out advanced directives, we've named our agents, but what does this look like before we're there? Because we're all going to come to the end, you know. And I think that's where really premier elder law firms are going, is really help, whether that's using a doula on staff, working with other professionals, or having someone in the office to do that, if we can get people to do it. Yes. Because, you know, and that's really what and that's what you're getting at with getting hospice earlier, if we can get people to understand what services that are there,
yes,
to let all that reconciliation happen. So it's not 2 weeks out, you know. And
it's tough because it forces people to have the discipline to look at something that, one, may create a lot of fear, may create a lot of anxiety, and it's just, they don't want to look at the fact that it's a reality, that, you know what, every one of us in this room, I mean, technically, we're dying.
Yes, but every day,
Yeah,
right?
we just don't.
We don't know the clock,
where it's
right?
going to be now.
That's
young
true.
newlywed recording this, not newlywed, but
Soon
soon
to
to be newlywed.
Yes.
She didn't want to hear that.
Oh, we all are, you know.
Yeah.
You know, and I think it really honestly speaks to. I heard someone one day tell me, you know, in America, Tyler, we don't die well, and I was like, what in the world does that mean? But it's just, I think, as compared to what I guess our Western European counterparts, but I don't know if it speaks to the decline of faith or just our cultural values in America or what that is, but I do think there's some truth to that it speaks louder to ourselves. Why is it, you know, that we have such a hard time, you know, I don't know. I think also this might be a human thing, right? As we all face the end of our mortality.
We're all individuals.
Yeah.
Type A driven people struggle with the fact that they're not in control of what's happening towards the end of their life. You have a lot of people, now faith is a major component. I can tell you people who have a strong faith tend to have the most beautiful experiences that are out there. And I do admit that I have a bias, but if I were to be honest, I'd have to say yes, there's a very big difference that way. The other thing that makes it so hard in not dying well is we're not really good at saying I'm sorry. Mm-hmm. We're not really good at saying I really shouldn't have done that. Please forgive me. I love you. You deserve more. You know, and
it
just settling that, because it all comes. And some of my most rewarding moments have been moments where we've had maybe spouses that have had historic problems, or an estranged child, or siblings that would not come together, where there was just anger and bitterness, hurt. Because, you know, when you're emotional, you can get angry, and that mouth can say things that you really in your heart of heart don't mean.
Yeah.
But you were mad at them, and can you humble yourself to ask forgiveness, you know?
I'm sure
But
you see
I'm
both
about to
cases.
ramble too much.
Yeah, but you see both sides.
Yeah, so that's a part of it.
Hospice of Tennessee, if folks are if they need more information, if they want a second opinion, you know, from their current physician, because again, right there's 6 months or less to live. We need there's a lot of medical guidelines here. Can they just reach out directly to Hospice of Tennessee to get more information?
They certainly can. They certainly can. And, our office right now is just off the square, right up the road actually, off North Dixie here in Cookeville. But we service multiple counties around the area. We're a part of a larger entity as well. So if you get further down towards the Sequatchie Valley, Hospice of Chattanooga is our sister company.
Yeah.
And we actually have a corporate umbrella to it. I know we're talking local, but you know, we just hit a milestone this past week where our organizations are currently serving over 7,000 families right now.
Wow, from Chattanooga to just in
Tennessee, northern Alabama.
Gotcha, this whole region.
So we're in a good size. We're in a good number of states, but that's a pretty good thing. We're there. You can find us on the internet, and quite frankly, if you call out and you say, "Hey, I have interest, you know, in learning more about this," I'm happy to talk. Now, in order to come onto our service, you need a referral from a physician.
Right.
You know, you do need that. You know, I had, can I tell a real quick caveat?
You're good, man, please.
Probably about 8 years ago, I had a story. There was a very, very sweet lady who had worked for 15 years as a hospice volunteer. And she was diagnosed with a heart condition that they told her one day would become terminal. So I, as a case manager, was going out to do an admission. And she's up there, and she all but had a tracksuit on and was doing jumping jacks and push-ups. So she walks me around her yard, shows me the 144 flowers that she planted that day. She's not short of breath. I mean, she's got no symptoms. I'm checking everything. It's all good. And I'm like, you know, okay, well, let's look at your records. Let's see what we could find. And we go through everything. And at that point, we couldn't bring her on service. She wasn't quite ready. And I think her physician sent the referral just to get her to leave them alone, right? Because they usually hounding. And I was talking with the daughter, and she goes, "Oh, no, that's my mom." I said, "Okay, well, look, we want to respect this. We'll follow her. We'll pick her up as soon as we can." She goes, "No, I don't think you understand, Mom." I said, "Well, how do you mean?" She said, "Well, Mom has a DNR, and one day Mom had a syncope. That means she passed out. She's gone." So here she's in a drugstore, and all these people come running out, and this kid comes running out with the AED, and she's like, no, Mom has a DNR. She doesn't want any of that. Stop.
Yes.
And this kid is sitting there, and he's looking, and he looks, and all of a sudden he starts checking for pulses. And at one point she's laying there. He says, "I think I feel a pulse." She popped her head up, said, "You do not," and threw her head back down. And I thought that somehow, that's a true story. And I said, so Mom was determined to get on her hospice, or later she did.
And later she did.
But it's funny how, you know, different folks have things, but it does require that. A lot of times, people find out maybe through a hospitalization, they don't realize they had a terminal condition.
Yeah, oftentimes.
You know, and so it's kind of quick, so we respond quickly to that, and social work will say,
Sean, if you had to, you know, talk about one leadership attribute that you see in your organization or that you try to follow, you know, as a liaison, what would that be for listeners as far as leadership is concerned?
I hope this doesn't sound too cliche, but I just try and follow the model of Christ. I want to be merciful. I want to be compassionate. I want to be kind. I want to be caring. I want to be truthful. I want to speak the truth in a loving way. I usually ask families. As a matter of fact, I just met a family earlier today where they knew it was an employee at a local healthcare facility, and they pulled me over and said, "I'm so glad I saw you." And they started talking about a loved one that may have a need. And we started talking, and I will always ask, do I have your permission to speak candidly but kindly? And they said, well, yes, because sometimes they're really not ready
For the truth. Yeah.
you to tell the truth. So,
Yeah.
so to do that in a truthful way. Obviously, you want to be ethical in everything that you do. But if I fail on mercy, compassion, and genuine love, I've failed.
Yeah.
Period. And I want to create an example where others will learn to do as I have done.
Yeah. Well, amen. That's seeking truth and mercy. I appreciate it, Sean Sullivan. That was great having you. Thanks for coming in.